Welcome to Exploring Long-Term Care. My name is Jesse Samples, and I'm the CEO of the West Virginia Healthcare Association and your host for Exploring Long-Term Care. Each month, we share information and provide resources on issues that will assist you in making informed decisions when it comes to you, your friends, and your loved ones that reside in long-term care facilities and communities in West Virginia. Today's program will provide viewers on information and utilization of therapy services in long-term care settings, and what are the reasonable expectations of residents, and what should they have in terms of services. We will discuss qualifications for services, who pays for therapy services, and how the recent healthcare reform legislation passed by Congress will impact the delivery of these services. Today's guests are Jack Spatafore of West Virginia Therapy Services and Ester Jones, Vice President of Operations. Thank you all for joining us today. We certainly appreciate it. And we'll start with ladies first. Esther, if you could just tell us a little bit about yourself and how you ended up in therapy services.
Well, my name is Ester Jones. I actually have a bachelor's degree in I have a bachelor's degree in medical technology from West Virginia University, and then I have a master's in occupational therapy, and I've been an occupational therapist for the last 10 years.
Oh, it's awesome. We really want to focus a little bit on occupational therapy as part of this. And Jack, how about yourself?
Jack Spatafore, and I started out education-wise with a master's degree in exercise physiology, comparable to like sports medicine, and wanted to take it a step further and end up getting a doctorate degree in physical therapy. So started out as a physical therapist, actually in an outpatient facility, a private practice up the road in Bridgeport, and it was involved a little bit with the nursing homes, when I started out, and along with a business partner, Greg Hayes, we saw a great need for a West Virginia-based company to provide long-term care in the nursing homes here. So it's really taken off over the last several years.
And how long has West Virginia Therapy Services been in operation?
We've been operating for about 4 years. 4 years?
Yes. And Esther, you've been with them the whole time? Or?
No, actually I've been with them for 2 years. I started out in subacute rehab, then subacute rehab with another company. And for the last 2 years I've been with West Virginia Therapy Services. And I'm very pleased at the changes and upcoming changes that we've been working on.
Oh, good. I know that the post-acute care segment has been the fastest growing part of skilled nursing facility services, in addition to what they normally do. Over the last 10 years, it's been a real focus on providing that post-acute care, subacute care type services. I know, myself included, a lot of times we talk about therapy services, and there's three kind of distinct parts that might overlap and then might be totally separate. Maybe you guys could explain to our viewers what the differences are between like physical therapy, speech therapy, and occupational therapy.
I'd start by saying occupational therapists, I always consider us monkey in the middle. There are some things that physical therapists do that we do components of, and there's some things with speech as well. Primarily occupational therapists, we look at your ability to take care of yourself, to be able to do the things. We look at ADLs and IADLs. ADLs are activities of daily living, which are basically the things you do to start your day, and like getting dressed, bathing, brushing your teeth, things like that. And then after you start your day, you have what's called IADLs, or instrumental activities of daily living. And those are all the other things that you do, like your grocery shopping, medication management, housekeeping, those things as well. So what we do is we look at patients who've had, or clients who have had changes and aren't able to do the things that they were able to do for themselves before. With that, which I know Jack will explain to you what physical therapists do, but sometimes, for instance, if someone needs help dressing, they may need to stand up to pull their pants up, and so we may have to work on the balance or the strength that they need to be able to do that, or we may have to provide compensatory strategies for someone to be able to do something safely and independently. As far as speech therapists go, with OTs being the monkey in the middle, one of the other things two things that they do that we do a component of as well would be cognition, which is your ability to think and reason things out and be safe when you're doing things. We look at that, and we also look at self-feeding. Most of the time we have to split things up a little bit as far as we're going to talk about healthcare and billing purposes, but there's something called duplication of services, so you can't do that. So for speech and OT, we like to say that occupational therapists, if you're looking at self-feeding, normally occupational therapists do from the hand to the mouth or from the plate to the mouth, as opposed to speech therapists. Most people think of speech as, I talk fine, why do I need speech therapy?
Right.
And they do work on speech, they work on language, they work on cognition, but they also work on swallowing and strengthening those muscles so that someone is able to actually swallow safely. So we like to say OT does hand to mouth, and then speech kind of takes it from there.
Takes it from there.
Yes.
And that's interesting, because I don't think a lot of people would associate feeding with speech therapy. But how critical it is to be able to swallow and those type of things in terms of developing it and rehabbing it, so to speak.
Exactly. And speech also, they work on audiology or hearing as well. And I think that's one thing that some people don't think of when they think of speech therapy.
Oh, that's awesome. And on the physical therapy side, there's probably a more common therapy that people associate with, but I think there's things within the therapy side too that might surprise for some folks, especially in long-term care settings.
Physical therapy, I think a lot of times people say, like you say, they say therapy, and you need therapy, and a lot of times physical therapy comes to mind first. It's maybe a little more prominent, because of people being associated with it in an outpatient setting or something. But in the long-term care, it's just an equal component to speech and occupational therapy. Our primary goals are usually based on safety and improving function, with transfers, getting patients building their strength and endurance, excuse me, so they can safely get out of the bed, get in and out of their wheelchair if it's needed. And then ambulation is a big component. But the unique thing in the long-term care is how we work together with occupational therapists and speech therapists. And a lot of times we actually co-treat. There's times that it's appropriate to treat, especially with speech, to be maybe a little more isolated and concentrate specifically on that discipline. But you see it a lot in the long-term care, where the speech, physical therapy, and occupational and physical therapists are working toward some common goals, and at the same time even.
Well, and you mentioned goals, and that kind of leads into my next question in terms of goals for the individual, the residents, and how they may vary between the assisted living community setting and maybe the skilled nursing setting. And so can we talk a little bit about what maybe the goals would be for like the assisted living community for PT, and then maybe it may not be as predominant in terms of services in the assisted living community for OT, but maybe speech would be part of that too. So what would be some of the goals and the differences?
As far as the difference between the two settings, they're obviously a little different type of patient. The assisted living would most likely be a higher level patient. So your goals might be, if that patient's going out with their family and traveling to, for example, transfer in and out of a car safely, where that might not be a goal for someone that's going to be potentially a long-term resident in a skilled nursing facility. So the biggest difference would be the level, or the level of the goals and the level of the patient. Cognition and speech are going to be probably more greatly needed in the skilled nursing facility, but assisted living, you'll see that as well. But there are some differences there, and it's just a different type of patient.
Right. And then even with assisted living facilities, a lot of times there are specific rules that you have to be at a certain level to be admitted into an assisted living facility, and you would like to maintain that level in order to stay there. So for instance, I know with assisted living, one of the facilities that we actually were in, they had you had 6 minutes that you had to be able to exit that facility in an emergency.
Right.
And 6 minutes might not seem like a long time, but if you're doing that from a wheelchair level versus doing that from standing, it makes a huge difference in whether or not you can do that. So OT is actually involved in some assisted living facilities. As far as I know, another rule that they have in a lot of them are being able to take yourself to and from the bathroom, which would be huge when it comes to an occupational therapist when we're looking at your ability to do things for yourself.
Right, and certainly in the advent that there would be a need to evacuate, a minute or two can be a big difference.
Exactly.
For the safety of those folks.
And then even from a speech standpoint as well, if we are focusing on swallowing, that would be huge, because a lot of the assisted living facilities don't have the same ratio of registered nurses to LPNs, and then there are issues with medications and being able to self-administer certain meds, or being able to, could they take care of a G-tube if someone was not able to feed themselves anymore. So speech would obviously be involved with that, with helping with the swallowing.
And one of the things that, as I alluded to earlier about facilities getting into post-acute care, more rehab type services, a third of the residents that are discharged in skilled nursing facilities are discharged to home, which really makes the occupational therapy and the speech therapy and the physical therapy critical components to getting individuals back to the place where they can actually be discharged safely back to a home environment.
Yes.
That's right.
What is the primary payer source for therapy services that are provided? We've talked many times on the show. Assisted living is pretty much private pay. There's no government assistance in the assisted living arena. On the skilled nursing side, where a lot of the therapies are provided, what is the primary payer sources for those services?
Primarily here in West Virginia, what we see is Medicare, Medicaid, as far as an insurance provider. You will have in assisted living, even though there's more private pay involved with their stay and room and board and such. If they have a medical necessity for a need for therapy, they still are able to use their insurance as far as Medicare, Medicaid, if that's what they have, and even private insurers as well. But in the long-term care skilled, you have it gets kind of complicated with Part A, Part B, but basically in general it's Medicare, Medicaid, and then if they do have a private insurance that covers all their therapy service and as you know, some of the room and board factors and other areas of the stay.
And what's the primary difference between Part A and Part B? If I was a listener or a viewer, thinking about what's the difference between Part A and Part B?
Well, the primary difference is the Medicare Part A is associated with the hospital stay, and it's usually a 3-day qualifying stay to be in the hospital. So your family member goes in a hospital, they're there for at least 3 days that they were admitted to the hospital, and now they're in need of skilled services to improve their function so they can go home. So that's kind of what, there's a lot of other rules to it, like you have to have a physician order, there has to be a certified bed. So there's a lot of other issues, but the primary thing from a viewer standpoint is that they need that 3-day qualifying stay in the hospital. I know from experience, we've had some family members tell us, well, my loved one was in the hospital for 3 days. Well, they were in an observation bed for one of those, and that doesn't count. So it's really important for viewers to understand that part of it is huge, because if that's not there, it doesn't matter about the rest of it. So for Med A, you have that 3-day stay, you're in need of skilled services, that you have a physician, that you have the certified bed, and you go to the facility. Medicare Part A, when it does kick in, does tend to pay for it pays for your room and board and your therapy services. So, and then there's rules to, they pay 100% for 20 days, and then if you have a secondary insurance, so other things come into play there. But the big thing is they do pay for the room and board and the therapy as well. Part B, that some of the residents, who we say residents when we're talking about people that live in a long-term care facility, they're the ones that tend to access the Part B services, and that's when someone has had a decline, or we feel that maybe they needed some time to get over a medical condition of some sort, and now they're ready for that pick-me-up. But at any rate, we deem that they're in need of therapy services, and they live in the facility, but they didn't have that 3-day stay. And that's when Medicare will actually pay for their therapy services. It's usually about an 80% ratio that Medicare Part B will cover that 80%. The other 20% is usually covered by secondary insurance, or if the person has Medicaid, then there's no charge for that other 20%.
Okay, all right. And just for the viewers that may have just joined us, you're watching Exploring Long-Term Care on the Library Channel, and today we're talking about therapy services in long-term care settings. And So we have Esther Jones and Jack Spatafore with us today from West Virginia Therapy Services. One of the things that we hear a lot of from the long-term care segment, the questions may come in, is that a loved one is in a facility, they're receiving therapy services, but they're going to be DC'd, jargon for discharged from therapy services. What exactly is happening there when somebody gets discharged from therapy services? What's the criteria for them to continue on receiving therapy services, and so that the viewer would understand what's going on there from the facility standpoint, because they need to understand that they have to be continuing to make progress, and once it becomes restorative or a maintenance type effort, it's different. Can you all explain maybe a little bit about that?
Yes. Generally, for anyone who's actually on therapy, we've done an evaluation to start with. When we do that eval, we take and we look at that resident, we compare, or that client, that patient, we compare them to what they're able to do now, and a lot of times what we'll do is we'll look back 6 months to a year and see what they were able to do at that time. And based on our schooling, our education, continued education courses that we've taken, and experience with the patients that we've worked on, we come up with a professional guess of about how long we think that patient will be on therapy in order to achieve the goals that were established on that evaluation. And those goals, we give you ideas of things that we can work on to help you get better, and then we meet in the middle somewhere. There are sometimes therapists want to save the day, and so there are a lot of things sometimes we want to work on that maybe that's not the client's goal. So we establish those goals together on that initial evaluation, and then we figure out a timeline of how long we think it'll take to achieve those goals. And in that time frame, a lot of things can happen. You can have someone who maybe has another issue that comes up that they kind of go downhill a little bit before they get better, or God forbid, sometimes there may be family issues that come into play where that patient just isn't as cooperative or mentally prepared to deal with that therapy. So there could be things, or that patient could have started doing cartwheels after we've done the evaluation, and they've just taken off and they're doing very well. So there are reasons why that initial date may change. From a Medicare standpoint, any services that we provide have to be deemed reasonable and necessary. So and you have to show that there's an amount of progress that's expected for that person to continue to be on therapy. So at some point when we're ready for a discharge, then that means we've either achieved the goals that were established and we feel that that person's at what we call max potential, or that we feel like they've therapists hate to say the P word, which is plateaued. So you've worked with a resident for a while and you're trying to get them better, but they're really kind of staying at this level. So there's a period of time where those services, the skilled services, aren't deemed reasonable and necessary anymore, and there's not that expected level of progress, and that's when you're given a discharge notice.
And that doesn't necessarily mean from the facility. That just means from therapy services. People should always keep in mind there's a host of complications that residents can have other than those type of needs. And they should also keep in mind that, don't underestimate their loved one, because they'll say, well, he'll never do that or she'll never do that. And they get into the facility and they do all kinds of things when given the opportunity. So,
one thing to add to Esther's excellent explanation of the discharge is in all the facilities that we're contracted with, we have a maintenance or some type of restorative program. So just for someone, a family member to see or read that their loved one's being discharged from therapy services, because of the reasons Esther mentioned, sometimes insurance is part of that. But we really try to implement continued care for that patient. So we may have met our goals with ambulation safely with a front-wheel walker with, standby assist, for example. And if we're no longer able to provide true skilled physical therapy, we try to turn that over to the nursing type program where they're still getting, good adequate exercise and walking and the exercise that they need based on where we left off with the patient. So that's important too for the family and them to consider as well.
Just don't leave them hanging.
That's right. We don't want to see them have a backslide, so we try to maintain the goals that we've achieved.
I also think it's important for your viewers to know that if a therapist is telling them, or the social worker, whoever happens to call them to inform them that we're going to be discharging their family member from therapy, that they do have the right to question that. They're supposed to be notified prior to the discharge. Ideally, we like to say about a week prior to discharge, so that family can come in and have that conversation, that interaction with the therapist, so there are no surprises. So,
Right.
for instance, if it was someone who maybe was not doing as well as we had hoped, maybe that family member coming in, kind of giving them a little encouragement might help. And we may opt to keep them on longer, or just letting them know that they have made their progress and they're ready for that transition to restorative or somewhere else.
Right, because
as well.
if therapy is the only reason that you're in the facility,
Right.
then it would be a discharge, not just for
Right.
therapy, it would be
Exactly.
discharged from the facility if that was the only need that they had while they were there. If someone has a dementia or an Alzheimer's type diagnosis, is that, or how does that impact receiving therapy services?
Right. There used to be the misconception that if someone has Alzheimer's, they can't have therapy because they're not capable of learning anything. And we found over the years that obviously is not the case. What we've actually found is that there are certain stages of Alzheimer's, or dementia, I should say, and at certain levels through repetitive instruction. So if you do give them the same thing over a period of time and structure the activities and structure the environment, that those residents actually do better. The other thing is that you can provide external cues. So even if internally they're not able to be safe to do certain things, we can change the environment and change the mindset and provide education to the people that are actually caring for them, so that they are able to be safe and as independent as possible, and that have their maximum as far as the quality of life is concerned.
Okay. If some family member may ask the question, if therapy service is going to make the resident more independent, but I'm kind of, that's why they're in the facility. They're in the facility for the facility to take care of them. What's your kind of response to that?
One of the big things is that they do need to understand that we're mandated by the government, by Medicare, to provide the best quality of life for that resident, and to provide for that resident to function at their max potential, and to have the potential to not have any what they call avoidable declines. So the only way that you can do all of those things is when there is a decline of some sort, is to have therapists come in to work with those residents to give them that opportunity to function at that higher level. I know dementia and Alzheimer's is a big thing, and I know they've changed some of the medications, and do you use this one, do you use that one, or what stage you use them. But one of the big things that everyone knows, they tell you to work on crossword puzzles and keep your mind stimulated, because that's what's going to keep you functioning at a higher level. So when you're taking that away from residents, and you will notice that maybe it did initially start out that person used to walk to the dining room, and now they're in a wheelchair, and that family member may say, well, I'm paying for them to take them, they should just take them in the wheelchair. Well, it started out as just going down to that wheelchair, but if that resident, that was their source of independence. I know when my car breaks down and I have to rely on someone else for transportation, it drives me nuts, because I'm used to being able to take myself somewhere. So we don't think about the level of independence that these residents have and that they want to continue to have. So one of the things we do is when we're working with them, we're going to help them to maintain that level, or at least show that we did everything to try to keep them at the highest level that they could be at.
The highest level of independence that they
exactly.
can.
Communication, Jesse, with the family is very important in that time. When if a loved one or family member comes to you with something like that, not only do we try to have to communicate with the patient, the resident, but it's a trying time for the family, putting a parent, a grandparent, someone in the facility. So we try to communicate the best we can with them and answer their questions. And there's a lot of different needs and different services available in that facility that can help them with those types of questions and concerns. And
do your therapists, do they participate in the care planning events that the facilities have, where the family members come in and they have staff that sit down and discuss the condition, and so your therapists participate in those type of care plans to facilitate that communication?
Yes.
Sure. Esther could talk for hours about that. It's a big part of what we do is that team approach with the facility, the family, and the resident.
Right. And ideally what we like to see is if it's someone who came from the hospital who is there for therapy and some skilled services, whether they're therapy and nursing or just therapy alone, within that first week that they're there, we like to have a care plan meeting to start with to establish that discharge and make sure everyone's on the same page of where they're going to go. The residents the patients that actually reside in the facilities that are on therapy and receiving those Part B services, those residents usually have at least a quarterly care plan of some sort that therapists, if they're on caseload, we're part of that as well, because the family involvement is huge. So.
Right. And you had mentioned earlier about continuing the therapy services maybe after they're discharged from, you've got kind of a care plan for that. Does your company also do home services and home care therapy type work? So if somebody was discharged and still needed therapy services, you all provide in-home therapy services as well?
We actually don't. Our company does not provide beyond the facility. However, we coordinate with them. There's, the documentation is open for, an open line of communication. It would really give the next therapist taking over, if they were able to go into the home but still require some therapy. You may have someone only for a few weeks that, say after a total knee replacement, that needed that special care and the safety measures that are in a skilled facility, but then they're ready to go to a, back home or even to an outpatient clinic. So,
and you all do operate outpatient clinics, is that correct?
We have I personally am involved in an outpatient clinic. So we will see patients that have maybe been gone from that process that you just mentioned, from the hospital to skilled nursing, maybe home health for a week or two, and then to outpatient, and then hopefully back to their normal functional level. So those are the good stories.
One of the services that we do offer, though, is we do home evaluations, so that if there is a resident that is going to be going back home and there is some concern about, sometimes residents will say, oh, I'll be able to do that once I get home. So, it's like, okay, well, let's go home. Let's see how you do there. And so we will take them out. There's, some restrictions in we make arrangements for the family member to come pick them up, and we follow them out. But we will go out to the home and we'll do an assessment. We'll measure doorways, measure the heights of surfaces. Then we'll have them do the actual transfers in their home environment. And if they were going to be cooking, we'll have them cook. Whether something what we call simple meal prep. But we will put them through the normal things that they would do in their activities at home. And then we give an evaluation, a write-up, and an assessment of any recommendations that we would have in order for them to be safe upon their discharge.
Okay. We only have about 30 seconds left, but I would like to hear, do we have a 20-second blurb on maybe what the health care reform that was just passed by Congress? And
my.
Can we give
us 30 seconds for that? Midterms coming up?
Coming up, you can't talk about that stuff with elections.
Maybe that's a good thing.
But maybe just a couple of points that people should be concerned about with this health care reform as it relates to therapy.
Personally, I have some strong opinions about it, being a healthcare provider. And, we're already seeing some changes. And I'm not saying they're all bad, but it's definitely changes that we need to adjust to and make sure that we're able to provide the high-quality service for those that deserve it. So it's a great obstacle for all healthcare providers.
As a company, we're being proactive with it as well. So we're making changes to how we practice in order to still provide those same quality services.
We really need to be focused on our documentation and showing medical necessity and making sure what we're doing is within the guidelines of the insurance companies.
Yeah, we might have to come back on and talk about some of the healthcare reform issues because the rules are being written as we speak, and things could potentially change real soon. So, but thank you all so much for joining us today. We certainly appreciate it, and we look forward to potentially having you back. And we hope the information that was shared on today's program is helpful in making informed decisions when it comes to you and your loved ones in long-term care. If you have any questions about today's program, please contact me, Jesse Samples, at the West Virginia Healthcare Association at 304-346-4575, or contact me via email at info@wvhca.org. Thank you for watching the Library Channel and joining us today on Exploring Long-Term Care.